Hello, everyone. Good evening and welcome to today's session. We'll allow a couple of minutes for our speaker to join. We should be logging on shortly, and then we'll begin. For those that just joined, just allow us a couple of minutes. Our speaker is logging on shortly, and then we'll begin.
Winters, is it a network issue? I saturated, we don't have the presenter yet.
Yes, so our presenter is trying to register first. I noticed that you register before you get access to the session, so he's doing that right now. Colleagues, thanks for your patience. The presenter should be with us shortly, but in the meantime, a link has been shared in the chat option for members who want to get some CPD points. So do use that link to accumulate some CPD points. And I think for those who have joined, you must have missed it. Zahara, if you could kindly share that for members to access. Otherwise, you're all welcome to this month's Day of Lung Science session, where we privilege to be handling a yet pertinent issue. And we do thank you for allowing us take care of your afternoon today. I think we should be having him shortly. Let me just pull up. So the link has been reshared. Do kindly utilize that for your CPD points. Perfect. So we have Dr. Sabiti. The mic is still not active. I think now it is. Yeah. So colleagues, welcome to this month's day of lung science session, where we are privileged to have Dr. Sabiti Wilbur, who I will be introducing shortly. I just needed to give some sort of background, whereas we know that there have been groundbreaking research worldwide that has, in a way, led to multiple licensed COVID-19 vaccines and therapeutics, and also improved our understanding of COVID-19. The ongoing potential of the virus to mutate cannot be overemphasized, but we also know that this is probably more challenging given the diverse population immunity. And for that matter, we cannot really be complacent in our efforts to develop new scientific tools and evaluate the new or the next generation vaccines and treatments. So to this end, the scientific community has had to call back on methods that had gained prominence in the 18th century, thanks to the works of Edward Jenner, for most of you who know those smallpox experiments. And this has been facilitated by the advancements in our understanding of different methodologies, but also the appearance of modern ethical frameworks and improvement in governance, among other issues. Early in the COVID-19 pandemic, the World Health Organization acknowledged the potential benefits of SARS-CoV-2 chimp. For example, allow the rapid prioritization of the vaccines. However, despite the wide availability of these effective vaccines against SARS-CoV-2, there remains a justifiable role for SARS-CoV-2 chimps. So ladies and gentlemen, colleagues, welcome to this month's Day of Lung Science. My name is Winters Mpamba. I'm a research scientist at the Lung Institute. And for this session, we are privileged to have in our midst Associate Professor Wilbur Sabiti. Now, I'll talk about Professor Sabiti just before I ask him to take the floor. So Professor Sabiti is an associate professor at the University of St. Andrews, but also heads or is a principal investigator on the Africa CHIMS program that we'll be talking about today, and is also a member of the Division of Infection and Global Health, still at the University of St. Andrews in Scotland. Professor Sabiti is a biomedical scientist, has interest in translational research, and has worked largely at the interface of applied biological science and healthcare provision. His work takes on a holistic approach, right from primary discovery to optimization in the laboratory, but also in the clinic. And he's done a lot in terms of diagnostics development. Most of you must have interfaced with the TB and COPD mycobacterial load assay, MBLO. And in recent years, he's led a group that has focused on the development and optimization of rapid diagnostics for the quantification of bacteria. So Professor Wilbur Sabiti, do allow me to humbly welcome you to this Day of Lung Science and ask you to take it on. So we'll have 1 hour for this session. We are 18 minutes late, but we'll have 30 minutes of presentation, And then at the end, we'll have 30 minutes of comments and a Q&A. So Dr. Sabiti, over to you.
Thank you very much, Dr. Mutamba, for that kind introduction. I think I do not need to add more on that. And I'm very sorry for being late. I am being introduced to the internet challenges in the LMIC setting. But I'm here and hope everything will progress well. I am seated somewhere where I hope this internet signal will be good and with no interruptions. So I'll try to progress quickly so that we catch up with the time. I'm more interested in your thoughts than I am to what I'll be talking about. So I want to give you enough time to give your views. And okay, yes. Share. So are you able to see my presentation? My slides?
Yes.
But you might need to put them in slides more. Okay, perfect.
Very good. Okay, good. So I'm talking about mucosal vaccine development in the context of controlled human infection model. I am Wilbur Sabit, as Dr. Mutamba has introduced, and I work with the University of St. Andrews in the School of Medicine, Division of Infection and Global Health. And I'm happy to be hosted by the Makerere Lung Institute, Makerere University, which is my alma mater. So I wanted us to start by understanding what mucosal immunity is. And so this is the immunity that is associated with what we call the mucosal cells or the mucosa. There are cells known as M cells, and these cells, I'm sorry, vehicles have started moving. Is the sound of vehicles interrupting your listening? Winters?
Good. It's all good. Just proceed.
You can hear me?
Yeah.
All right, fine. Let me proceed then. But just be aware that the vehicles have started setting off and making some noise behind me. So the M cells and then the epithelial cells, which have villi, and then the mucus that kind of oils the villi and the epithelial cells. So within the epithelial cells, we have the M cells. So most antigens do go through what we call the M cells. And within the mucosa, there are lymphoid tissue, and these are known as mucosa-associated lymphoid tissue, or MALTs. So once the antigens have been captured within the mucosa, then the local immune response is provoked. And this may lead to what we call the common mucosal immune response or the systemic immune response. That means then the activation of factors that are in the blood and going into all other organs. So mucosal or the mucosa can be categorized. So it could be the respiratory tract mucosa or the gut mucosa or the urinary tract mucosa. And the image I show here is the one for the respiratory tract mucosa. Again, characterized by the M cells, which associate or where the antigens tend to interact and gain their entry into the inner side of the mucosa. So this is an image of the respiratory M cell that is now associated with the lungs. And I think this is of interest to you at the Lung Institute to understand what immune factors are associated with the respiratory mucosa. So we have a number of T cell factors, B cell, dendritic cells, which become activated of macrophages here, B1 lymphocytes, and other cytokines that are activated as soon as the antigens get associated with the mucosa. So lymphocyte tissue associated with mucosa of respiratory tract, gut, urinary tract, and all associated with the exocrine glands within these organs. So their job is to protect the internal of the epithelial cells. So they are there to make sure the epithelial cells are protected because they are the first line of defense. So here are schematic diagrams to show what the landscape of the mucosa. So we have the M cells, the lymphocytes associated with the M cells, the dendritic cells. Then M cells take up antigens from the gut lumen by endocytosis. Remember, there are two types. It could be transcytosis or endocytosis. If the engulfing is being done by macrophages or other white blood cells, this is called phagocytosis. And if it is being, the engulfing is being done by non-professional phagocytes, it's in most cases called endocytosis. So once these antigens have been endocytosed, they go to the inner side, the internal side of the epithelial membrane. And once they're there, they gain, the dendritic cells capture them and present them to the other immune cells. And here is the human diagrammatic kind of schematic diagrams showing where these mucosal lymphocytes are found in the lungs, in the gut, and part of the urinary tract. And then those are what we call the naive lymphocytes, which normally enter the mucosal tissue from blood. Then we have what we call the effector lymphocytes, which disseminate to the mucosal surfaces in the lung, tonsil or adenoids, gut, and genitourinary tract. And so these ones come in to fight off the antigen. That's after presentation. Then the effector lymphocytes come in to wage the battle and kill off the antigens. So in terms of vaccine development, this is now what kind of antibodies are associated with the mucosa. So the most common antibody isotype is immunoglobulin A. And this is produced after the dendrites have presented the antigens to the T cells, and the T cells activated the B cells, and then the plasma cells begin to produce the IgA. So there are two types of IgA isotypes, the IgA1 and IgA2. So IgA1 is most associated with blood, though we can also find IgA2 in blood. IgA1 is a monomer, so that means it has got only one one immunoglobulin chain, while IgA2 is a might chain antibody. So IgA2 is quite resistant to digestion by digestive enzymes, and that's why it's most commonly associated with the gut. So when we are talking of mucosal immunity, we are thinking of inducing IgA response that will now deal with the pathogen or the antigen. So in terms of vaccine development, what we're trying to do is we get the appropriate antigen and we introduce it through the inductive site. So this would be the part of the mucosa that is full of the naive M cells. And once the antigen has been, or the immunogen has been introduced, then it's captured by the M cells. Then the dendritic cells receive it from the M cells and present it to the T cells, could be CD4 or CD8 cells, and these activate the T cells activate the B cells through the adaptive immune response. Then the B cells differentiate into plasma cells through interleukin-5 or interleukin-6, and then we produce either the polymeric IgA, and these IgA antibodies are now specific to the antigen that has been produced. Normally, the target of a vaccine is to induce production of these specific IgA antibodies that will keep on fighting the pathogen today, tomorrow, and for many years to come. That is the purpose of a vaccine. So induce a specific antibody response and memory B cells, which will stay for a long time, providing the immune response or immunity to the affected person. So dendritic cells are quite important, and CD4 T cells, which interact with the antigen and activate the production of IgA by the lymphocytes. And then this results into a cascade of cytokine and specific antibody response, which is activated. So this is, in short, the vaccination process, what we intend to achieve when we vaccinate. So in COVID-19, we had, as you know, COVID-19 is caused by SARS-CoV-2, which is a coronavirus. And it's important to note that it first infects the mucosal surfaces of the upper respiratory tract and the gut. So you remember in the early days, we were all thinking of, oh, we should only wash our hands. And we forgot that this is a respiratory disease. It goes through the nose. This exposure leads now to the infection of the mucosa. The virus may also be acquired via the mouth and conjunctiva of the eye. So the inductive and effector immune interactions occur primarily at the mucosa. So that's why the mucosa is very important. And as you know, the current COVID-19 vaccines are only able to prevent, they do not prevent infection. They are only thought to reduce severity of the disease. So means that if we have vaccines that can target that can operate at the mucosa level, then we have a higher chance of preventing infection by the virus, for example, SARS-CoV-2. So what is the traditional way of developing vaccines? So in most cases, the antigens or the immunogens that we want to induce the immune response are first investigated in mice. So mice are sort of the workhorses. That's where maybe the first trials, investigations of how the immunogenicity of the antigen is done. As you know, the mice are mammals, but they are far, the family Rodentia is far from the humans, the Homo sapiens. So, but the mice will give us sort of a rough idea of the immunogenicity of our target antigen or epitope. Then some studies also involve tissue culture, whereby we could use immortalized cell lines or what we call primary cell lines. Immortalized cell lines, these are cell lines that are developed from cancer cells. So these cells keep dividing. They have lost their mechanism of death. So these ones can be multiplied many times or many passages and can be used to characterize different molecules in the lab. A slightly advanced part of tissue culture is where we use primary cell lines. So these ones are isolated from the human and used to investigate either a pathogen or any other molecule outside the host. So after these stages, preliminary stages, we can go a step higher and do what we call non-human primates, which are used to assess the initial phases of assessing efficacy. But sometimes people move right from mice to humans. So not all the vaccines go through the non-human primates. But for things like Ebola, which are very lethal, it's quite hard to use, to just jump the humans. So it's better then to go through the non-human primates like chimpanzees, monkeys, and others to assess the efficacy. Then the sort of final stage is the human phase, where we go through the phase 2 for investigating the safety, then phase 3, phase 4 for efficacy and effectiveness of the vaccine. Now, what is vaccine development in the context of controlled human infection model, or what we call in short CHIM? So CHIM, this is a process whereby a human being is directly exposed to the pathogen to cause infection. And then this is done in a controlled environment. And this participant, or the human who's participating in the study, is monitored very closely with all that is needed to make sure that this pathogen that they've been exposed to does not kill them. And so in that case, there must be what we call rescue interventions. For example, if the participant develops a very severe infection, then there must be medication that is effective to make sure that their lives are saved. But the hope is that for some of the pathogens, they are not very lethal, and that means the person may survive through without even having a severe disease. And as you may know, COVID-19, the lethality or the case fatality was roughly 1 to 2%. And in the African context, 99-point-something% just survived with COVID, some of them without any symptom. So that increases the chance of thinking of the a controlled human infection model for SARS-CoV-2, given the fact that in the majority of the people, it causes asymptomatic infection. So the value of the CHIM is to fast track vaccine development. So instead of going through all these other stages, primates, whatever, once you have a candidate, a very good candidate, vaccine candidate, you go straight to the human and begin to assess all the process just from the human being. So it skips some steps in the development process. And there are two types of CHIM. We have what we call the primary CHIM. This is deployed to understand the viral pathogenesis or the pathogenesis of the pathogen and the natural immune response, and also to determine the dose or the inoculum that causes the infection. So this is the first stage. You want to understand in a controlled environment, when somebody is infected, challenged with the virus, what processes that occur for infection to be established, and then the pathology and the symptoms to occur, and how and whether you need intervention or not. And so how many of the virus particles do you need to inject in order to cause the infection without overdosing and maybe overwhelming the participant. And then we have what we call the secondary CHIM. This is whereby the participants are vaccinated first, and then after they've been vaccinated, they are directly exposed to the virus or challenged with the virus to assess which is the most effective mucosal vaccine candidate to be taken forward for the open human population trials. So some of you might have heard of what we call the AFRI-CHIM. This is a kind of a proposed project that will be investigating SARS-CoV-2 or COVID-19 in the context of people being challenged with the virus directly. The participants must be healthy and must not have any underlying infections. So all assessment is done to make sure that whoever is joining the study has nothing that predisposes them to severe infection. And then they will be challenged with the virus and then monitored, assess the pathogenesis, the pathology caused by the virus. And then once that is done, the dose is determined, and we know which is the best dose to use for infection. Then the second stage is enrolling a new set of participants, and these participants will be also healthy, nothing that is in their body that predisposes them to risk. And then they get a vaccine. And once they've been vaccinated, they get challenged with the virus. The purpose is to assess which is the best mucosal vaccine that can prevent infection. So we want to make sure that COVID cannot cause infection at all. So once the best candidate has been selected from the secondary team, then that best candidate is taken forward to the open population vaccine, whereby you vaccinate everybody and then kind of do surveillance assessments to see how good the vaccine is preventing COVID infections. As you may all know that COVID is still around and is still causing infection in Uganda and also in other countries of the world. So don't be deceived that you're no longer hearing COVID on the news. It's actually still around and still causing infection. So the fact that people are working with it, then that increases the possibility that this is an asymptomatic disease, and so being exposed to the virus may not cause severe infection. So I want to end with this slide, and I will leave it open later because I need your thoughts about the controlled human infection models in terms of developing a COVID-19 vaccine. So what do you think are the safety concerns? What do you think are the ethical concerns? Do you think this is possible in Africa? If yes, what should be done to make it a success? And I acknowledge colleagues from the University of St. Andrews, the AfriChim Consortium, which is made of 7 African countries plus 3 European countries. I also acknowledge SACO, which is the Coalition for Equitable Research in low resource settings. And the Makerere Lung Institute, which is our host today, and also the coordinator of the AfriChim, and SEPI, who is hopefully going to be the funder of the project. And the funders below are the funders who have been funding my research for many years, especially EDCTP. So that's the end of my presentation. And I go back to this slide and welcome your thoughts about this matter. Thank you. Over to you, Winters.
For that nice talk, for taking us through that nice presentation, right from the basics to where we are now. And I think you actually stuck to the 30 minutes I've given you. So that saves us, because we'll have 30 minutes for Q&A or comments. And colleagues, do feel free to raise your hand and either comment or ask a question. But while you do that, I just wanted to come in and, of course, again, emphasize from what I hear, Wilbur, it seems that CHIMs might be the way to go in a way that you actually save on time, especially as most of you know during COVID-19, time was of essence. We needed vaccines in a very short time. And looks like these new methodologies might be the way to go in terms of being both efficient, but also produce medical interventions in a short time. I do also note that I think the other added advantage the CHIMs might give us is that you're able to tell when the infection happened, as opposed to if you did the usual trials we normally do, where you're not able to tell at what point the infection happened. And I think that allows us the possibility or the advantage of us being able to characterize the viral kinetics in detail, but also to be able to study the host immune responses post-exposure. Having said that, I do welcome comments, questions from the members online. Do feel free to open your mic and go for it. Any questions, any concerns or comments about what's currently being projected? As we wait, Wilbur, just one question for you. Of course, initially, when you start thinking of deliberately infecting a human being, people will be concerned about safety, largely around the morbidity and mortality. And the question to you would be, how then would you make sure you do not probably cause more harm than good in any participant if you were to do a CHIM? I think that would be the first question from my end, but we'll entertain more questions from the members online.
Thank you for that question.
Hello?
Hello.
My name is Josephine Tegamanyi. Thank you very much for the presentation.
Josephine, can you let me first answer Winter's question, then I'll come to you? Are you able to hear me, Josephine?
Yes, it's okay.
Okay, fine. So Winter's asked how do we make sure that people are safe, the participants? And the good thing is that there's been a lot of experience that has been accumulated or gathered over the few years we have been managing COVID. So there's a lot of clinical experience on how to manage COVID. And I know some members of the Lung Institute are still involved in treating COVID patients. So we are in a much better position than we were at the beginning. I know at the beginning we were all kind of scrambling with what to do with the COVID patients. But now the medications that can save life are already known. Our supportive management is already known. So there's a good chance that whoever gets a severe infection, they can be managed successfully. And the other thing is that the advantage with Africa is that it's a population of young people. And this study most likely will be recruiting people maybe between 18 and maybe 30 years, really young people who are less vulnerable or less susceptible to severe COVID disease. So I think with that, there's a 99% chance that every participant will complete successfully without any harm. Josephine?
Thank you very much. For me, my concern is about the vaccine development. Now the candidate vaccine that we are talking about, I don't know if I got you well, that some vaccines do not go through the CHIM, the primates, but they go straight to humans. I don't know if this candidate is also going to go through all stages, and if it doesn't go through all stages, I'm concerned about the safety of the vaccine in humans. Thank you.
Thank you, Josephine. That's a granted concern. The vaccine candidates, which that will be put forward to vaccinate the people, will have gone through all the other processes, either through mice and maybe some other phase 1 studies to make sure that they are generally safe before they are introduced, because they are coming at a level whereby we are assessing them for their efficacy in preventing infection. So before you come to that, then you should have looked at the safety. So the safety aspect of the vaccine will be covered before these candidates put forward for assessment in the context of the controlled human infection model. Thank you, Josephine.
Thank you. James, your hand is up. Go for it.
Thanks so much, Dr. Winter. Thanks so much, Professor Wilbur, for this wonderful presentation. It has been informative. My safety issue of safety concern is about longer time side effects. For example, if I admit this participant, how long are we supposed to have him admitted as a monitor? For example, we have to look at issue of if you look at longer time side effects, how long are we going to follow up on this participant? Then another issue is if you can look at the risk of infection. In the case of he gets infected, is not protected by the candidate vaccine. Okay, that one I talked about it, about managing how to manage in case of infection, but basically longer term, non-longer term effects. That's the issue of safety concern I'm looking at, and maybe the issue of ethical clearance, because based on the experience with the clinical trial of natural therapeutics, there is a lot of questions with IRB, so we need to have maybe industrial training with IRB so that they can easily pass out such a protocol. Thank you. Over to you, Chair.
Thank you, James. Aline Itwe. I mean, these are really good questions. And Winters, I hope you are taking note of the recording is happening, because these are good questions that we, the researchers, need to think about as we develop our protocol. So how long do you review or keep this participant? So based on what we know so far in terms of the incubation and the symptomatic phase of COVID, I think it was traditionally 14 days, whereby within 7 days, the symptoms come out, and then maybe the next 7 days, the virus clears out. So we are hoping that the assessment maybe could be 28 days, and this participant is tested until when COVID-19 cannot be detected in their samples before they can be released back to their communities. Now, when they are released, we do not forget about them, because we are also interested in the long-term immunity. What is the quality of immunity 1 month, 3 months, 6 months, 12 months after the natural infection or after the vaccination? And also there are issues of long COVID. So those participants will be monitored for another 12 months to ensure that they are not coming up with anything to do with long COVID. And just for your information is that participants will be highly insured so that they have the best of care for whatever happens. But yes, there will be at least 12 months of follow-up to ensure that there are no side effects coming off the exposure they had during the study. Have I answered both your questions, or I've left out some?
Thank you much, Professor. You have answered me. Thanks so much.
You're welcome, James.
Thank you. And of course, you touched on the issue of long COVID. But one thing, this is probably to emphasize the point, that before a participant gets into CHIMS, what is now becoming apparent is that the screening has to be very rigorous. You don't want to enroll a participant who most likely might actually have severe disease or probably end up with long hospitalization or even death. So the screening has to be on point, but also the follow-up is quite intense. And in terms of screening to make sure people do not get long COVID and all that, I think now, of course, thanks to science, we know the risk factors for long COVID. So you didn't want to enroll participants who are at risk of long COVID. Eva, your hand has been up for a while. Kindly unmute and go for it.
Well, thank you, Winters, and also thank you, Professor Sabiti, for this wonderful presentation. So it's a brilliant idea to have CHIMS, though we also know that if something is good, there'll be positive effects and also negative impacts. But how the community perceives CHIMS is something on a different level. Some people might understand. So maybe my call would be, what public advocacy are you going to put into place when the study is going to commence? Also, then you'll have to look at maybe the community engagement perspective of this, as well as involvement of social media, because depending on what the community perceives what the study is about, then it will determine whether people will positively embrace the CHIMS or not. And then also from the biology, we also know that most times vaccine efficacy varies across populations depending on the vaccine strain that you're inoculating into these people. So maybe that is what you're going to study, whether what would the efficacy be in this study population, but you'd have to put that into perspective. And then when it comes to the ethics, I think you might get a bit of fire from that area. So you may have to you have to first empower the ethics committee, and they have to unlearn and then learn that actually these are things that should be embraced, and that it's okay to jump some steps along the vaccine development pipeline if some of the basics have been done. So empowerment has to take place there. But yeah, that's what I wanted to say. All in all, thank you for the presentation. Over to you.
Thank you, Eva. I think that's a great observations. And you mentioned the issue of community engagement. You are right. The community engagement must be effective, and the messages must be crystal clear, free of ambiguity. And this will be done in stages. And as you mentioned about the ethical committees, the concerns that they may have, and the fact that they need to unlearn and learn, that is really important. I think, Eva, you should join our community engagement team. I don't know, I also staff at Makerere Lung Institute, because you already predict what they might ask. So good. So we want to make sure that the community engagement is effective, but the engagement will start with regulators, and that is the ethical committees and the regulators like the National Drug Authority, and also the government, the Minister of Health, the technical arts in the Minister of Health, so that they are all on the same page. There's no doubt. They are clear with the message. So before the message goes to the general public, then it's already been assessed and agreed upon by the regulators. And then involvement of the media and the civil society. Those are critical stakeholders in terms of engaging the wider public. So those ones will be engaged first to save them from being confused and then saying things that confuse the rest of the public. So those will be engaged and they will be involved in developing the message that is going to be communicated to the wider public, and also engaging some politicians as well as part of the public engagement. So that is, it's a must do, and it will be part of it. So my presentation today is sort of like a teaser or a tester, because the real thing will come at a later stage. And I'm happy you're already envisaging the things that should be done to make this a success. Eva, have I answered your question fully?
Yes, you have.
Thank you.
Augustine, I see your mic is open. Please admit. Okay, thanks, Wilburn. Thanks for the 4 asked questions. We still have 15 minutes for more questions or for discussion. So members, kindly open your mic and have a go. Let me see if we have any mic that is open. I don't see any, but while members coming up with questions, Wilbur, I have one more question for you. In terms of manufacturing these pathogens, Augustine, do you want to submit?
Winters, can you also be checking the chat? Some people might have put questions in the chat. I see. This is Professor Pauline Biachik, I think. We are training Rex on CHIMs through EDCTP funded project. That's good. I think there's a CHIM project, Schistosomiasis CHIM, that's now ongoing at Uganda Virus Research Institute. And the research ethics committees have already been engaged in this. And thank you, Pauline, for highlighting that the Rex here in Uganda are receiving this training through an EDCTP funded project. Good.
Thank you.
Any other question, Winters?
Yeah, I wanted to give the members an opportunity. Augustine, apparently we can't hear you. So...
can you hear me now?
Yes.
Yes. Thank you very much, Professor. This is Dr. Augustine Ongoli. Just looking at it from the experience of COVID, there were some variants of COVID that were very dangerous, like the Delta, that happened to kill actually even the younger people. And with the experience I saw, even when I called the people in ICU Mulago, those who went to critical illness, almost all of them died. From our CTU, those who were severely ill, like when they turned critical, all of them died. Now, if I'm the one who is convincing, who is enrolling someone in the study, with that experience, I'm not yet convinced to go and really tell someone to participate. So I don't know how you can make me understand. Thank you very much.
Thank you, Augustine. I think that's a really good concern. And we need people like you on the round table, because we must convince you beyond reasonable doubt before we even go to your clients, to your patients. Because if the doctor, the expert, is not convinced, then you have no hope of convincing someone from the public. So and you're right to mention the Delta variant. which was, I think, the most lethal in the Ugandan context. But for your information, Augustine, the majority of Ugandans, if we were to do statistics, you'll find that actually over 99% walked with that virus scot-free. And you remember that's the time when the president asked that the young people, the school children, school-going children, university, where every school closed, and said, go home. They all went home, and sadly, the virus spread to their old grandmas and their old parents, and those are the ones who got severe disease. So I think the idea of making sure that the participants are of young age is important. And I know you noted that even some young people died. Yeah, sadly, yes. There will always be some exceptions. And I think the strain that is going to be used is going to be the circulating strain. And now most of the strains we have are Omicron variants. And these Omicrons have been found to be really quite weak in terms of virulency. So we hope that they won't cause severe disease as we saw in the Delta variant. So, but as I think Eva noted, the infection severity varies from population to population. For example, people in the UK, Europe, and America, they were almost really got severe disease almost at equal rates by every variant that came. And yet in Africa, the first, the wild type really kind of passed through without people noticing. People are still asking, where is COVID? We don't see it here. It's only the Delta variant that was a bit virulent for the African population. And I think that's a good point that we shall raise with our partners in Europe to make sure that the variant that is used for Africa is the variant that has low chance of causing severe infection. I hope I have convinced you, but I still will invite you for a cup of tea and we talk more.
Thank you, Wilbur, and thanks, Augustine, for that question. Of course, the other issue is, the other way to approach this is in teams, there is the possibility of using the attenuated strains of some of these pathogens. So that's one other way you could probably limit the effect of the participants. I see a question from Joseph online. What methods are available to study the pathogen post-interactions at molecular level in relation to teams?
I can't hear somebody speaking. Who is that one speaking?
Hello.
Are we now okay?
Can you hear me?
Yes, I can hear you well.
Yes, this is Josephine again.
Yes, Josephine.
We've been looking for participants with COVID-19, and these days it's quite a challenge to find positive participants for COVID-19. I don't know the number of participants that you're looking at and what strategies have you put in place to make sure you get these participants that are going to be to participate in this study? Thank you.
Oh, that is, Josephine, that's good news for us, because we want people who do not have active infection of COVID. So we will be screening, in addition to screening all other underlying health issues that may predispose them for severe infection, we will also be assessing whether they have any active infection immunologically, and also antigen tests like the PCR, to ensure that there's no infection with COVID. So the low prevalence of COVID positive is good news for us, Josephine. Thank you for highlighting that.
Thank you. Wilbur, you have a question on chat from Joseph about the methods available to study the pathogen-host interactions at molecular level in relation to the CHIMs.
All right, thank you. And so these will be the immunological methods to characterize the immunity. There will be genetic methods which look at some of the genes underlying the immune response, and also the genotype. We are interested in knowing do certain genotypes associated with more strong immune response than other genotypes, and that is from the human side of the story. And then, so at the Uganda Virus Research Institute, they already have an immunology lab that can do most of these characterization assays. And then where we do not have the assays or the facilities, those samples may be referred to our European partners to do the assessment. But our target is to be able to do all the assessments that we need to be done, because we want to build capacity, research capacity in Africa. We don't want to do this once and then forget about it. We want to make sure once we build the capacity, it's there for even other studies, CHIM and non-CHIM studies, or other clinical trials. So we are keen to develop capacity to do all the assessments at molecular, immunological, and general population level.
Thank you, Wilbur. And I have a comment from Helen Opolot, and I hope this is Helen from the National Council of Science and Technology. CHIMS is possible in Africa if supportive regulatory frameworks are put in place. Uganda has a joint scientific and ethical review framework, which is used to review these complex studies. I think that's quite reassuring, Wilbur, that is coming from a regulator. Helen Opolot is from the Uganda National Council for Science and Technology.
Yeah, thank you so much, Helen. And yeah, that is reassuring. And we will make sure that comments like yours reach the funder, who is a little bit still worried that regulators in Africa might resist, to show them that actually regulators are positive about this kind of study taking place in Africa. So thank you very much for your comment.
Thank you. Colleagues, we still have a few minutes to make our submissions, but in the meantime, do make use of the link in the chat section for your CPD points. Zahra or the admin could kindly reshare so members can place that link for their COPD points. Samson, your mic is open.
Yes, thank you so much, Dr. Winters and Professor Sabiti. I was only just looking at probably, yeah, it's safety, but on probably the other hand also efficacy. Okay, so you talked about, there's that slide where you were talking about when the history began with, I mean, how vaccines were developed, maybe using animals, the animal model. And then now you talked about the primary and the what. So I was just thinking in my mind that before maybe we could get into the human beings, I was like, could we first use cells? Actually, what was coming in my mind is where you have like a cellular laboratory where we are, first of all, probably dealing with cells before you can get directly into, I mean, the human being. So I don't know whether that can be done now, or it is not possible to do it that we get into, the human being. Because of course, yeah, usually there will be those worries that how will it be, in terms of safety, yeah, because safety, I think, is the biggest issue in as far as vaccines are concerned. Yeah, and then the other thing that I am also still thinking about is when you're talking about the variants. And now let's take as an example that this person had maybe like three, I don't know whether that can be possible, like 3 different variants that that person had. And of course, yeah, we say the person cured and is okay. So what is the implication there? Because now which vaccine now, which one are you now targeting? So that is also where my dilemma, which one are you targeting? And then how about the rest? Is there a health implication? Yeah, so that's just what I wanted to ask that maybe you can enlighten me about. Thank you.
Thank you. Would you please remind me your name?
Yes, this is Samson.
Yes, Samson. Thank you very much for your observation and your question. So in terms of the safety of the vaccine candidate, that will be assessed with every procedure that is available before it's brought to the human level, because we are assessing this candidate in its ability to prevent infection. So at least there should be some idea that this vaccine candidate works somehow, somewhere. Either they've used tissue culture or they've used some other animals, and before it's brought straight on. But the good news in this, even if it was just a candidate and it's brought direct, the idea of the SARS-CoV-2 chim is not new, because in London, at Imperial College London, the SARS-CoV chim was done in the early days of COVID, when we hadn't knew anything on how to manage severe COVID infection. And it was successful. None of the participants actually got severe infection or died from the exposure. And now we know a lot of how to manage COVID or severe infection. So I think we should be able to have successful exposure and management of any severe infection. Does that one answer all the questions or only one? Samson, have I answered all your questions?
Yeah, I want to believe so. Though, of course, yeah, I was trying to also find out that I don't know whether that is still the procedure, the issue of where we are.
Winters, am I the one off?
I don't know whether that, yes, answers it.
Oh,
I'm just trying to bring out the idea of a cellular lab where we are, because it's like we are not talking about the animal model now, but we are like, first of all, dealing it with this, cells that have been withdrawn from someone, blood that has been withdrawn from someone. And then maybe we see whether it is working out there before we can get it to the human being. That's what I'm saying, is that, can that also be possible? Or it is not possible?
You mean trialing it in other models before it goes to human being?
Yes, apart from, of course, the animal model. Now this one I'm talking, where we are getting cells. Okay, drawing blood from someone, And then we first deal with the blood before we can what? Get into now, pushing the vaccine into the human body. Of course, still you're dealing with the same candidate, but then what I thought was that you could first get in the blood, and then later on, you can now, when you've seen what has taken place with the blood, so what has happened, and then there you are then getting the vaccine. Because I'm looking at a scenario like maybe where we're using plasma and directly putting it. So I was like, maybe directly introducing it to the human body. So is it possible, first of all, to deal with that plasma before you can get into the human body directly?
Yeah, so what will happen, Samson, is that the first stage will be the what we call the primary chim, whereby humans are naturally exposed to the virus, or they are challenged with the virus, to investigate the natural cause of infection and the natural immunity to the infection, or immune response to the infection. Then while that one is being done, there will be researchers. Some researchers have already done, I understand, a research institute in Kenya is already investigating one of the mucosal vaccine candidates. So while we are understanding how the chim works, the other labs will be, or clinical units, they will be now investigating the candidates that are to be put forward for the secondary chim. So I am sure no stone will be left unturned in terms of preparing the vaccine candidates to be used in the secondary chim, which involves vaccination first and then exposure to the virus. Does that answer your question?
Okay. I think that is fine. That's fine now. Thank you.
Thank you, Samson.
Then the issue of the variants. The variants, was it, so I'm like, if you maybe targeted one of them, do the other ones also have an effect? Because what I know is that at the time the person had the variant, he has already developed an antibody. And we are very aware that those antibodies are specific to that very variant. So that was my worry, that does it affect the efficacy of the vaccine, or on the other hand, does it maybe again cause any other reaction to the body in terms of, maybe development of other antibodies or something like that? Maybe that's what I also wanted to understand.
So, so do you mean COVID variants, the SARS-CoV-2 variants?
Yes, that's what I meant, yeah.
Okay.
Yes.
So your worry is that if we have now chosen our candidates and then we have exposed them to this type of virus, and this vaccine is proved to be effective against infection with that virus, what happens if there's another variant that comes up that could dodge this vaccine? Is that what your question is about?
Yes. The whole, maybe, I don't know whether there's variant interaction, or with the vaccine, that kind of thing.
Yeah. I mean, those are uncertainties that come with every vaccine, because if you vaccinate maybe focusing on a certain serotype or whatever, and maybe another serotype comes later and the vaccine is not effective. But we are hoping that we will, with the mucosal vaccines, which are more or less working on the interface of innate immunity, they are able to deal with every variant that comes across. So that's why there's interest to the mucosa, because the other COVID vaccines that we have are not mucosal vaccines. And that's why they have not been able to prevent entry of the virus and causing infection. So we hope that this vaccine that can work at that interface of the mucosa has a higher chance of preventing entry of every COVID-19 variant.
Okay.
Yeah.
I think that it makes it very clear. Thank you so much.
Thank you, Wilbur. I think our time is getting fast spent, but I will allow one burning issue from anyone online before we bring this to a stop. Anyone has anything burning in 1 minute? Oh, okay, looks like, yes, Silva. Make it very, very short.
Yes, it's just that I had actually put it in the chat because he had highlighted the use of Omicron, but you know that its infection course is very small. How do you intend to assess the post-infection? Just that. Thank you.
Okay.
30 seconds, yeah.
Yeah, so Omicron came as sort of an example of the idea that it's the circulating virus that will be used for exposure. And so far, those ones who are following global COVID surveillance and prevalence and genomics, I think the majority now that are circulating are Omicron variants. So Omicrons are good at actually causing infection, but they are not good at causing severe disease. So for us, in that case, they are good news because we don't want severe disease. We want to establish infection and know how it works, even even the context of someone who is asymptomatic, to understand what is going on in their body while they are infected with such a virus. And then the next step is introduce a vaccine and then check if you can completely prevent a variant like Omicron from penetrating into the cells. Because actually Omicrons have proved to be very good at causing infection, though they are weak at causing severe disease. So in a way, they are good actually variants to use in the context of CHIM.
Okay, thank you, Wilbur. Apparently, or unfortunately, we have to bring this to an end, but allow me to appreciate you for this wonderful presentation. Thanks for introducing us to CHIMS and the process of vaccine development. I want to thank members who attended today's session. Again, reminder to use the CPD link in the chat section for your CPD points. I think what we can now take home is that actually this is very possible, and probably this might be one of the best things that ever happened in Africa, but also for Uganda. And we definitely need to embrace it. Of course, it affords us an opportunity to try and understand how these vaccines work. If you know, most of the vaccines have been developed from elsewhere, but we know the dynamics in the African population are quite different in terms of genetics, infectious disease history, co-infections, the immune status, environmental factors. So it's very possible that actually these vaccines might be doing differently or perform differently. So we have an opportunity to develop these vaccines here, but also be able to evaluate them in our settings, given that diversity in the African populations. I also need to let you know that CHIMS has been deployed for other illnesses, malaria, cholera, typhoid. Our neighbors in Kenya have taken that step already for malaria, the same thing in Gabon and Tanzania. So the earlier I think we start this, the better. So it's one of those things everyone should be able to embrace. I also need to make one announcement that the Day of Lung Science is one of those premier programs for the Lung Institute that happens every month. And next month, we'll definitely be looking forward to hosting you again for yet another important topic. So be on the lookout for when that will be happening and when that topic, what topic will be discussed. Thank you and have a great evening.
Thank you, Winters, and bye. And thank you, everyone who came.
Thank you, Wilbur, for the presentation.
Thank you.
Wonderful.